Two women had cataract surgery on the same Tuesday morning, in the same operating room, by the same doctor. Ruth is 73, a retired school librarian from Dubuque, Iowa. She's 75 years old, a retired bookkeeper, and lives 4 streets away. They were to have surgery within 40 minutes of each other. Same gear, same laser, same able hands, same perfect operation, both eyes, no complications. It was in the car on the way home that Ruth cried because she could see for the first time in 11 years the individual leaves on the oak tree in her front yard. Eleanor has not taken the highway each night since then. The streetlights burst into glowing rings. Oncoming headlights explode into prickly white stars. She stopped driving to evening choir concerts for her granddaughter. She canceled her Wednesday night card game. She told her family it was because she was worn out, not because she was tired. Same surgeon, same day delivery, same surgery, 2 totally different lives. And here's the truth that almost nobody outside of medicine ever explains. That operating room did not solve the difference between Ruth and Eleanor. A decision Eleanor did not know she was making 6 weeks ago, in a consultation chair, in a conversation that lasted less than 2 minutes. Cataract surgery is one of the safest, most sophisticated, most successful operations in all of modern medicine. In the United States, nearly 4 million are performed every year, and worldwide more than 20 million. The operation is not the risky thing. It is one sentence you say in a chair, in your own clothes, weeks before anyone touches your eye. It is the most dangerous moment of your whole cataract trip, and once you've said it, it's there forever. No refunds, there is no exchange office. You changed your mind, there is no simple swap next spring. You will live in that one decision every waking moment of the rest of your life. Every morning, every road sign, every face at your dinner table, every grocery aisle price tag, 11 p.m., every screen on a phone. And most patients don't do that, not because they don't care, not for want of intelligence, for nobody had ever told them that a decision was taking place. Dr. John here. I'm a board-certified eye doctor. 28 years in practice, tens of thousands of patients, more consultations in that exam chair than I could ever count. And I have to tell you something today that your doctor's 15-minute appointment has never had time to explain. Patients spend 6 weeks looking into their surgeon. They read every review on the internet. They ask their neighbor, their sister, their congregation. They flip and flop, worrying about a 10-minute procedure they'll barely feel at all. And then they walk into the consultation completely unprepared for the only part of the process that is truly permanent, truly theirs, and truly in their control. So, before we go any further, do something for me now. Leave a comment with your age and 1 word about your driving at night. Fine or hard. That's all. We read every single comment and respond with personalized suggestions, so please do not hesitate to share your thoughts. And if you've had cataract surgery, tell me what lens you were given, because your comment might be the one that saves the person reading it below you. Today I'm sharing the 8 mistakes I see patients make with this decision, year after year, decade after decade. Stay with me all the way through, because number 5 is the one that blows people's socks off. It's a perfectly normal, perfectly treatable condition that millions of older adults have been told not to worry about, brushed aside as just getting older. And it can silently skew the measurement that sets your permanent lens power before your surgeon even picks up an instrument. Hardly anyone connects the two. You will by the end of this video. But first, 30 seconds of anatomy because everything else hinges on it. Your natural lens is situated behind the colored part of your eye. Think of it like the lens on a camera. All it does is bend light that comes in, so it hits a nice sharp point on the back wall of your eye. That lens when you were 20 was clear as spring water, and it was flexible. It could contract and release by itself, so you could look at a mountain range and then look right down at a book without even thinking about it. But over the decades, the proteins inside that lens start to clump. It is cloudy. It turns yellow, like the window of an old farmhouse that has gone brown and foggy. That fog is the cataract. Colors go dull, and whites go beige, smear headlights. And it happens so slowly that most people don't realize how much they lost until it's returned to them. Cataract surgery works beautifully, an opening in the surface of the eye. The cloudy natural lens is gently fragmented and removed, and a brand new artificial lens is placed in the exact same pocket where your lens used to be. That man-made lens is called an intraocular lens. It's a clear disc smaller than your pinky fingernail, and it stays in your eye for life. And this is the part I need you to take in. This is the video in a sentence. Your natural lens may change focus. Almost no artificial lens can. Your surgeon has permanently locked in its focusing power in the operating room based on a decision made weeks ago. When you choose your lens, you're not choosing a little piece of plastic. You are deciding for all time which distances in your own life will be seen without glasses and which will require glasses. That is the decision, and only gets made one time. Here are now the 8 mistakes. First mistake: believing that surgery is the part that gives you the result. This is the basic error, and all the other errors stem from it. Patients put all their worries into the operation, none into the choice. But how well you recover depends on the surgical procedure. The lens you choose determines how your world will appear for the next 20 years. The American Academy of Ophthalmology's preferred practice pattern for cataract in the adult eye makes it clear that lens selection should be a shared decision, based on your particular eye measurements, your other eye conditions, and your real daily life. Shared. So, you're meant to be in the room, awake, participating, not nodding. If you take one thing from this video, take this. The operation is the easy part. The difficult part is the consultation. Stay with me, because the next one is the mistake that ensnares the most people. Error number 2. Choosing the lens, an undoable decision. Patients say yes to whatever lens is recommended, quietly assuming that if it doesn't work out, somebody will fix it. I get the assumption. Every other purchase in modern life is accompanied by a receipt. This one doesn't. Removing and replacing a lens that has already healed into place is a much more challenging operation than the original cataract surgery, with significantly more risk to the delicate structures inside your eye. It is over. Surgeons do this. But it is a rescue, not a comeback. The Journal of Cataract and Refractive Surgery has explored the reasons behind premium multifocal lens removal. The reasons for this were primarily loss of contrast. The world looked washed out and dim, light phenomena, halos, and glare, and patients whose brains just never adapted to the lens. These are not operational failures. Those are mismatches. The operation was fine, and the lens was wrong for that guy. So make this decision like you'd sign a mortgage, not like you'd order a sandwich. And stay tuned, because the next mistake is the most costly one I see. Mistake number 3. Assuming the expensive lens is the better lens. Here is where most patient disappointment begins, and I want to be very careful and very fair here, because premium lenses make a great many people genuinely happy. The workhorse of the world is the standard monofocal lens. Mono means one sharp focus distance. Your surgeon sets it for distance, almost always, so after surgery you see roads, faces across a room, television, horizon, all clearly without glasses. The trade-off is simple and perfectly predictable. You buy reading glasses at the drugstore for close work. That is the whole compromise. This is the lens covered by Medicare and most basic insurance. Excellent, clean, high-contrast image quality, minimal side effects. Multifocal and trifocal premium lenses are not identical. They have several focal zones built right into the disc itself, and they split the incoming light to serve far, middle, and near distances simultaneously. The brochure promises freedom from glasses, and for many patients that promise is a very real one. But this is the physics you never get to see in the brochure. That light is not augmented, it's divided, and your brain has to sort through layers and layers of overlapping images to pick the one it wants. Next, 2 things could happen. First, the contrast is lessened. The sharp separation between light and dark is a bit muted, and this is most noticeable in dark rooms and at dusk. Second, point sources of light at night can bloom into halos, glare, starbursts. This is not fear-mongering. It is one of the most consistently replicated findings in eye research. 20 randomized trials addressing this exact question were pooled in the Cochrane database of systematic reviews. People who wore multifocal lenses were much less likely to need glasses, confirming that the marketing promise is real. The same patients were also about 40% more likely to report glare and about 3.5 times more likely to report halos than those with standard monofocal lenses. This same pattern was observed in another meta-analysis, published in Graef's Archive for Clinical and Experimental Ophthalmology, And these lenses are usually an elective upgrade, which means the costs are out of your pocket, usually in the thousands of dollars per eye. So here's the fair trade. You pay real money for that, and it's a permanent risk to your night vision, but it is real freedom from glasses for many of your daily tasks. That is a great trade-off for the right patient. Eleanor avoids the highway for the wrong patient. Before we go any further, I want to make sure you understand something because I do not want anyone leaving this video scared. Premium glass isn't bad. Monofocal lenses are nothing wrong with. There is no such thing as the best lens. There is only one perfect lens for your eye and for your life. The whole tragedy of this decision is that the patients are handed a menu and they are not told which dishes are going to make them sick. All of the other errors in this list are related to matching. Now this is where it really gets important. Mistake number 4, not telling your surgeon how much you drive at night. The one lifestyle fact that should probably carry the most weight in your decision about lenses is the fact that is least often volunteered by patients. If you drive regularly at night, to work, to church, to your daughter's house in the winter when it is dark at 5 in the afternoon, then nighttime halos and glare are not a minor cosmetic annoyance. They are a daily annoyance and a safety issue. According to a review published by the American Academy of Ophthalmology, as many as half of all cataract patients in the early weeks after any surgery report some degree of unwanted light phenomena. Most of it settles as the brain adjusts. But if you have chosen a lens that deliberately breaks up the light, you have increased the chances that some of it never quite makes its way home. If you drive a lot at night, that really pushes you toward monofocal lenses, toward the newer enhanced monofocals, toward extended depth of focus lenses, or toward monovision, which I'm going to explain in a moment. But if you haven't driven at night for 6 years and your world is your kitchen and your garden and your books, that changes the equation entirely. Say it in the consultation. Say it out loud. Say, I drive at night and I need protection for my night vision. You can't read that from a scan. Now then, mistake number 5, and this is the one I promised you. This is the one where almost no one sees it coming. Mistake 5, relying on the untreated dry eye to determine your permanent lens power. And because this connection is not at all obvious and it makes a huge difference, stay with me. Before the operation, the eye is measured, very accurate. Machines take measurements of the curve of your cornea, the front window of your eye. Those measurements are used in a formula to determine exactly what power your permanent lens needs to be. All downstream depends on those numbers being correct. Now, that front window is covered with a thin film of tears, and the light has to pass through that film first. If the tear film is not healthy and breaks up too quickly, the surface of the eye is no longer smooth and glassy. It's uneven. Try to measure the exact shape of a window pane through the streaks of dried rain. Research published in BMC Ophthalmology found that treating dry eye disease before surgery significantly improved the accuracy of intraocular lens power calculation. A study published in Scientific Reports in 2024 found that dry eye increased short-term variation in these very measurements, meaning the same eye can produce different numbers on different days. And influential dissatisfaction research in the Journal of Cataract and Refractive Surgery found that one of the most common contributors among unhappy multifocal patients was a remaining refractive error, the very kind a bad measurement creates. And that's what makes it so cruel. Older adults with dry eye are frequently told it's just a normal part of aging. Gritty, tired, watery eyes late in the day. A little burning when you read. You say it, you get drops, and it never gets attached to anything important. And then it quietly distorts the one measurement that is permanent. If you have any dry eye symptoms at all, I want you to bring them up at your consult and ask directly if your ocular surface needs to be treated first, before your measurements are taken. A decision that will last 20 years can be protected by 2 or 3 weeks of treatment in advance. That is the entire point. And bear with me, because the next one is the most heartbreaking mistake, in my opinion. The 6th mistake, ignoring the other conditions already in your eye. This is the most damaging mistake I see, and the one that patients most deserve better information on. There may be more to this than just your cataract. Age-related macular degeneration, glaucoma, damage to the optic nerve, diabetic changes of the retina, chronic severe dry eye, and irregular cornea from your LASIK in 1999. Each of these conditions already costs you some contrast and some light sensitivity. You're already working with a smaller light budget. Then a multifocal lens takes that diminished light and divides it. You're piling one deficit on top of another. This is precisely why a major review in the journal Ophthalmology and long-standing guidance from European and American cataract surgery societies both caution against multifocal lenses in patients with significant retinal disease or moderate to severe glaucoma. Monofocal lenses are almost always a cleaner, sharper, more reliable option for the rest of their lives. Remember that study on surgically removed lenses? A good many of these patients had a pre-existing condition that should have ruled out the premium lens from the outset. So, your other eye conditions are not an afterthought at the bottom of your chart. They are the bedrock of this whole decision. Let me ask the question bluntly. Based on what you tell me about your macula, optic nerve, retina, and cornea, is a light-splitting lens a good idea for you at all? So, stay with me. The next mistake can undo a perfect surgery by itself. Error number 7. Never asking if you have astigmatism. Astigmatism just means that your eye is a little more shaped like a rugby ball than a basketball. All of it. That jagged curve blurs sight at all distances, near and far. That's what patients don't realize. If you have meaningful astigmatism, and it is not corrected during your surgery, it doesn't matter how expensive your lens was. You can buy the best premium implant there is on the market and you will still be reaching for glasses all the time because the blur is coming from the shape of your eye and not from the lens inside it. There is a fix, and it is a well-known one. It's called a toric lens, a version specifically designed to counteract that uneven curve, and it can be combined with almost any class of lenses. Surgery can also fix astigmatism by making precise cuts into the cornea, and this is normal. In a study of more than 4,500 eyes being prepared for cataract surgery, about 35% had at least one full diopter of astigmatism, enough to be clinically meaningful. However, the proportion of patients receiving astigmatism correction is much lower than the proportion of patients that would benefit in many regions. So ask, out loud, at your consultation, do I have astigmatism? How much? And just how do you plan to correct it during my operation? If you don't understand the answer, ask more. And mistake number 8, which is also the great, hopeful, wonderful news of this whole video. Error number 8, never trying out your future vision when it was so easy to do so. In medicine, every permanent decision is a leap in the dark. This one doesn't have to be. There are 3 ways to reduce the guesswork, and almost no one ever hears about all 3 of them. The first is monovision. No need for a premium lens here. Your surgeon uses 2 standard monofocal lenses, but makes one eye sharp for distance and the other for close work. Your brain just switches between the 2 automatically. No conscious effort involved. Many patients are mostly glasses-free, but with the clean, high-contrast image quality of simple single-focus lenses. But some brains can't take it. Some people notice their depth perception gets softer, or driving at night is harder. And this is the beautiful part. You can learn in advance. The American Academy of Ophthalmology recommends trying contact lenses to see if the patient can tolerate the difference between the 2 eyes. Your optometrist will fit you with 2 trial contacts, one for distance and one for near, and you will wear them through your normal life for about 2 weeks. You drive at night. You read the paper. You make dinner. You scroll through your phone. If your brain snuggles in happily, you found a great, inexpensive solution. If it makes you dizzy or wobbly, you just avoided a permanent mistake for the cost of a box of trial contacts. The second is staging. If both eyes require surgery, perform one, wait several weeks, then do the other. Live your new image, drive it at night. Then, with real information instead of a brochure, decide about the second eye. If you're disappointed with something about the first lens, you've still got one choice to play with. The third is genuinely new, and this is the most promising news in this field for years. There is now a lens that can be light adjusted, first approved by the American Food and Drug Administration in 2017, with a second-generation version available since 2021. It is the only intraocular lens that can have its power changed after it is already inside your eye. It is made of a material that can be adjusted with precise ultraviolet light treatments in the office, typically a few weeks after surgery, so you and your surgeon can fine-tune your vision, test it out in your real life, and then lock it in permanently. The adjustments led to a substantial increase in the share of eyes landing within half a diopter of target in a study published in the Journal of Cataract and Refractive Surgery on patients with previous laser eye surgery, historically the hardest group to predict. It's not for everyone, it's not right, it's not accessible, it costs extra, and you have to go to the follow-up appointments faithfully. But it is there, and it deserves a place on your list of questions to ask. I'll also tell you what's changed in recent days as well, because the honest answer is that the middle ground has become so much better. Enhanced monofocal lenses, outcome data behind them in 2025, extend a single focus point far enough to give useful intermediate vision, computer screens, dashboards, price tags, without the added glare and halos of light-splitting designs. Extended depth of focus lenses do a similar thing over a longer range, and in the last 2 years, newer extended depth of focus and trifocal options have entered the American market. The choice today is really not just cheap versus expensive. Ask your surgeon what's new since they last explained lens options to a patient like yourself. Any good surgeon will love that question. Now here's what I want you to do this evening. Just one thing, and it's free. Take a piece of paper, note down 5 answers. Number 1, how many nights a week do I drive in the dark? Number 2, what close-up work really consumes my days, and would I care about reading glasses? Number 3, what other eye conditions do I have, including any dry eye symptoms and any laser surgery from years ago? Number 4, what can I really afford without resentment? Number 5, am I willing to wear trial lenses for 2 weeks before I decide? Fold up that paper, take it with you to your appointment in the pocket of whatever you're wearing, and when you sit in that chair, put it on the desk and say, before we talk about lenses, this is my life. Then ask the one question that gives away everything. Ask your surgeon, if he had my exact measurements, my exact eye conditions, and my exact daily routine, what lens would he choose for his own eyes and why? Listen to the full answer. A surgeon tells you everything you need to know and walks you through the trade-offs honestly. Something two has told you so in a sales pitch sounding kind of conversation. And if it feels fast, if you feel pressured, if someone is asking you to decide today, say the most powerful sentence in medicine. I would like to think about this, and I would like a second opinion. There are almost never emergencies that require you to pick a permanent lens on the same afternoon as your eye exam. A thoughtful surgeon will respect that fully. Anyone who hasn't has answered your question for you. Now I'll tell you the rest of Ruth's story, for it was no luck. Ruth came into her consultation with a piece of paper. She told her surgeon that she drove to her sister's house at night twice a week, that she had been putting drops in her eyes for gritty eyes for 3 years, that she had early changes in the back of one eye, and that she didn't mind glasses for reading one bit because she had been wearing glasses since she was 48. Her surgeon treated her dry eye for 3 weeks, remeasured her eye, corrected her astigmatism with a toric monofocal lens, and set her for distance. Ruth purchased the cheapest, least advertised, least glamorous lens in the entire catalog, and she's one of the happiest patients I've ever talked to. She looks at the leaves on her oak tree. She drives at night without a care. She has a pair of $2 reading glasses in every room of her house and thinks that is the funniest, best bargain she ever made. That is the point. And the happiest patients aren't necessarily those who paid the most. It was they who knew that a decision was taking place and who made it fit their own life. You've worked too hard for the life you have. Your freedom, your driving, your books, your grandchildren's faces, your walk in the evening. None of that should be decided for you in a 2-minute conversation that you did not know was the most important one of the whole process. The technology here is amazing. It is a true modern success of surgery. The only variable remaining is the one that is entirely yours. Now you know it. So do me a favor. Right now, share this video with someone you love who is over 60 years of age, especially if they have been told they have a cataract or if they have stopped driving at night without telling you why. Give it to a wife, a brother, a neighbor. Your part may be the reason someone walks into their consultation prepared, not persuaded. That's not nothing. That's someone's next 20 years of sight. And if you are not subscribed, please subscribe right now. We are pushing for 1 million subscribers because that's the number that tells the algorithm this information needs to be seen by every older adult looking for it tonight, the night before their appointment, when they need it most. Then leave a comment and tell me which of these 8 mistakes you almost made or already made If you have already had your surgery, tell us what lens you got, and if you would choose it again. Someone reading this comment section next week is 3 days away from that consultation chair, and your one sentence may be the thing that changes their mind. This video is for educational and informational purpose only. This channel is not a substitute for professional medical advice, diagnosis, or treatment. Always check with your doctor, eye doctor, ophthalmologist or optometrist, or other licensed healthcare professional before changing anything in your health or vision care. My name is Dr. John. See you on the next video. And there is one thing that I intentionally left out of this video. I have never told you what happens years after the cataract operation, when your sight slowly clouds over again and patients panic, convinced that the cataract has returned. It hasn't. Cataracts do not come back. What is really going on has a name, is very common, and it is corrected in about 60 seconds with no incision at all. Hardly anyone is warned about it beforehand. That's what the next video is about.